So it's my honor to introduce our close colleague, Dr. Michael Desjardins. He's worked on multiple projects with us. Michael Desjardins is an assistant scientist and core faculty member in the Spatial Science Center in the Department of Epidemiology at Johns Hopkins. His general research interests are medical geography, spatial epidemiology, spatial statistics, and modeling. He's applied these to multiple research areas, including COVID-19, cholera, cancer, accessibility, mental health and suicide, substance abuse, aging, childhood health, residential mobility. I'm not even going to list all of them. He has funding from NSF, NIH, and the Maryland Department of Health. He co-teaches multiple classes at Johns Hopkins, including GIS, spatial statistics, and spatial design applications. Yeah, and he's been to us at App State. He's been an incredible mentor to our students, which has been really beneficial for them, particularly where we are at App State compared to Johns Hopkins. And we appreciate him. We're so lucky to have him. So thanks for coming.
Well, thank you, Maggie. The first time I met Maggie, I was a master's student at Charlotte back in 2016. So it's weird how that ends up like this. So she's in the audience now. And it's been great working with Maggie and App State and all the students. One of the better geography programs I've seen across the country. So you should be very grateful where you are and keep up the hard work. And hopefully this inspires you to maybe get into health. So maybe you don't know what medical geography is, the link between health and place. It should be somewhat intuitive if you've been following COVID and whatnot. So I'll go over that briefly. I'll provide a brief background of medical geography all the way back in the 1850s with John Snow. Maybe you've seen the map, read the book, the Ghost Map, right? The role of geography in public health, it's everywhere, and spatial people are quite needed as in schools of public health. And then I'll go over 2 case studies from my work with Maggie and team at App State on mental health, and one on a recent publication on access to gynecologic oncologists in the US. And then I thought it'd be a good idea to show where does a geographer fit in public health, some career opportunities, and then Q&A. So thank you all for attending. This is the first non-hybrid talk, all in person, but I think it's still being recorded, so technically hybrid. So yeah, the famous John Snow example in 1854. I made my medical geography students read that book to discuss it over the first few weeks, because it's really the first prime example of using data, spatial data, to solve or address a public health problem. So in London, in Soho, in the downtown area, there was cases of cholera, a huge epidemic, I think 40,000 plus cases over a short period of time. And back then, germ theory wasn't a thing before Louis Pasteur, right? And they thought miasma, or bad air, was the cause. Poor people were more likely to get and transmit disease. And he thought this was kind of silly because he was looking at the patterns. He started to go out and write down where people were dying and where they lived and who had cholera. And he found out by making this map, which is, I think, the first exercise we do in our fundamentals of GIS. And he shows that cases are closest to the Broad Street pump than to all other pumps in the city. And this is a technique known as a Voronoi tessellation or diagram, which you could do quite easily in GIS. And that was his hypothesis. Let me turn off the pump and the cases should subside, which they did. And it was still decades before germ theory was widely accepted, but he was pretty much the first one to show that cholera was a waterborne disease and using a map, which was great. So if you ever want to pay homage to Dr. John Snow, I've been to this pub a couple years ago in London. It's quite nice. Most people don't care. They're just there to drink and eat fish and chips, right? But here you have the replica pump outside, and they have a little, I guess, plaque where the actual pump was. And it just has a lot of cool history inside too, newspaper articles from the epidemic back in the day and so on. Okay, so, I think the power of spatial science for public health really took off. It was already there, but the COVID pandemic definitely put us front and center, thanks to the Hopkins dashboard, which, I'm pretty sure everyone has seen it. Everyone asked, was I on it? No, I looked at syndromic surveillance, which I'll briefly talk about later, made our own dashboard for that. But I worked with Frank a little bit, just giving him some tips, and it got better over time. It's just a visualization dashboard, but it was just a really amazing place to go and see what's going on in your country, in your state, all the way down to your county as well, tracking this every day. And the cases were publicly available, so that was good for researchers like myself that could do more advanced analysis. So that was shut down in March 2023, but you could still use the archive data. And yeah, after this dashboard, everyone has a dashboard now. So I think it's good to learn how to disseminate your stuff online for others to see, even if it's just a simple map. Stakeholders like that a lot, and I'm doing that for various projects. It's tedious, but it's important, and people will pay attention more. So there's a little portrait of Jon Snow. So what is medical geography? So it's really understanding the impact of local and global environment and every other scale in between on health outcomes. A subsection is spatial epidemiology, which is looking specifically at distribution of diseases, mapping patterns, forming etiological hypotheses, and so on, where medical geography as the umbrella category encompasses everything, access, exposure, and so on. So just looking at this quick diagram, we know that health is made up of individuals to form our public health, right? It's influenced by various things, environmental, physical environment, built environment, and also socio-demographic factors. So there's an inherent nexus between health and place. So where does GIS fit? Pretty much everywhere. So you could represent people with points on the map, aggregated data, polygons, and of course, you have your environmental, socio-demographic data, which could be in your attribute table or represented either in raster or vector format, right? So what are some questions that we can ask? So I guess first I'll go down to the bottom. Don't quote me on this, but my professor back in the day told me that about 80% of all human decisions involve aware. So life is inherently geographic and spatial. So when we think about public health, where do individuals live? How does that impact their exposures and outcomes, their activity spaces? Where is a disease clustered? There's a bunch of techniques to determine what a cluster is. Some are better than others. I'll showcase one of those today. Generator for a NIMBY problem, for example. Where's the nearest hospital? Where can we intervene, and so on? We could do a lot of cool things by tracking people's activity spaces in space and time, looking at trajectories, looking at mobility, how that impacts your kind of human environmental interactions, and then just overlaying layers. I don't need to really explain that. You're in geography, you're doing GIS, and making hypotheses from that, where you would go beyond the map and do spatial statistics. Obviously very useful to track exposure and risk. On the left here, we have childhood lead poisoning in Philly. So if you were to combine a bunch of layers, I know you can't really read that part for me as well, but you have different risk factors, children under 6, proximity to certain things, lead concentrations in the soil. You can combine all those layers to make an index of risk for lead poisoning. And as you can see, it's quite high in Philly, in certain areas. And you can do the same, in this example is in Oakland, California, where if you look at the side-by-side maps, most of the lead issues, at least when they check their blood, the highest risk of lead poisoning were in areas with high poverty and of minority non-white populations. So I think this is one of the better graphs you'll see on the different scales that we work with. So going from short and fine to broad and over long periods of time, longitudinal. So of course, every day you go to school, run errands. Within your neighborhood, you have your activity space that's pretty almost certain throughout the week. You might have periodic stuff, like on the weekend, you go hiking. Seasonal things, obviously, the flu is seasonal, of course. And then long-term exposures over life. Certain cancers might take 10 years to pop up, right? We've seen that with cancers from 9/11 being a first responder, people dying over a decade later. And then if we look at spatial scales, we have obviously neighborhood, like I said, you have intra-urban, maybe you're commuting to another county for work, like I do from Bethesda, an hour to Baltimore. So even though I'm surrounded by a bunch of neighborhoods, I have more of a relationship with Baltimore than those neighborhoods close to me. So thinking about autocorrelation, things like that, it's more complex than Tobler's first law states, right? So then we get all the way up to global spread, all these things that happen, which we could use with GIS and spatial statistics. So risk factors, should we expect these risks to be higher in areas where population density is higher? This depends. Infectious disease, definitely. You think about R0 or attack rates of disease, obviously you need a lot of people for that disease to transmit. But if we think about more environmental issues, radon poisoning, probably don't really care about the population that much. So it really depends on what you're doing. But typically, yes, an infectious disease, we consider population, use Poisson models, stuff like that. And then, of course, you can look at access, look at spatial patterns of dentists per 10,000 in North Carolina. This map's not that informative. We just know where there's a lot of dentists. Is it a function of population? Probably. And then we could do other things, look at the relationship between access to dentist and say gum disease and other things. So just thought I'd throw a North Carolina map on there. And then some stuff in Florida. This is from a while ago, CEP grant with my former PhD advisor, looking at access to care for mothers with children with birth defects like spina bifida and other things, cleft lip, and so on. So just seeing how travel impedance impacts kind of the outcomes in long-term care. People move a lot. Actually, there is someone, or actually maybe 10 or more people that moved 5 times in a year, moving all over the state to find the best care available. They're probably wealthier, have better insurance and so on. So things to consider. So that's medical geography in a nutshell, right? There's an inherent nexus between health and place. We could use spatial to account for that. A lot of the times when you have basic regression models, the model will be stronger if you incorporate space, because if you look at the residuals of a regression, if they're highly autocorrelated, that means you're really not taking account into the error. There's probably some spatial effects going on that you didn't adjust for. So looking at our research, I'll present 3 different examples. The first 2 papers I published with Maggie and students and other faculty. The first looking at place-based differences in suicide and suicide-related outcomes among adolescents and young adults in North Carolina at the county level, I believe. And then we have evaluating co-occurring space-time clusters of depression and suicide-related outcomes before and during the COVID pandemic. And that was just published, I think, last month. And a recent paper that took quite a while to do, working with some MDs at Hopkins. We have disparities in potential access to gynecologic oncologists, so not OBGYNs, the specialists that will treat gynecologic cancers in the US from 2001 to 2020. And then other stuff that I do that might trigger more interests, what you could do with spatial health. So the first example, we published this in the Journal of Adolescent Health with Maggie, Jen Runkle, Lauren Anderson, and myself. So we know suicide is an ongoing public health crisis among youth and adolescents. And not a lot of studies look at kind of the spatial patterning, especially at small spatial scales, in the subpopulation for adolescents. So we know due to the COVID pandemic, we've seen rises in nearly 30% since '99, and the COVID exacerbated that rate as well. Among adolescents, the group we were interested in, there was a 38.6% increase in North Carolina between 2007 and 2018. And then there's obviously a lot of precursors to suicide attempts and successful attempts. And these are on the rise, including non-fatal self-injury. So thanks to Maggie's grants and connections with different data sources. We have emergency department data, death certificates, violent death reporting, system data for North Carolina for a decade to investigate spatial clusters of self-injury and suicide. So it might be difficult to see. I'll just kind of summarize table 1, just showing the distribution of our data. It's pretty much 1,398 suicides, and we have over 48,000 self-injuries reported in this data set. 80% were men, so definitely more men than females. The mean age was 19. For suicide, 17.9 for self-injury. And then we look at race, ethnicity. We look at firearm poisoning for the suicides that wasn't available for self-injury. And then we look at incident year from 2009 to 2018. So suicides were on the rise. We started with 90, and by 2018, we had 189 reported. And same with self-injury. Started at 3,200, and by 2018, we had 8,300. So I'm not going to go over the methods and details. Some of you are already using SAT scan and cluster detection. So what we did is we wanted to detect statistically significant clusters of suicide and self-injury separately using the spatial scan statistic. So we define a cluster as distinct areas of excess relative risk or incidence of either of the two outcomes compared to everything outside of that area. And we adjusted for age and gender at the zip code level. So we also used a regression to see what was kind of influencing the occurrence of those clusters within those clusters after we detected them, looking at a variety of individual level and community level factors. So the first map is just looking at the spatial clusters that we detected of both suicide. Next one is self-injury. The first one, suicide, we have 4 clusters throughout the entire state. The thing with SAT scan and cluster detection is that you have all these different areas that are contributing to the cluster, but because the search window is a circle, not all of the zip codes are going to have stuff that's really important or influencing the cluster. So you might have zip codes without any observations at all. So the first map kind of just shows the relative risk generally of the cluster, and then within that cluster, we have the relative risk of each zip code to see what places are actually contributing to the cluster to make better public health decisions. So anything in white in the map shows areas that have a relative risk of 0, and then anything less than 1, 0 to 1 is lower than expected risk. So we're really interested in zip codes with higher than 1. And then for self-injury, as you can see, a lot more smaller clusters scattered throughout the state, and a lot more observations, of course. So the highest cluster in terms of relative risk was in the Northeast there. And we have a bunch of clusters scattered throughout central and western North Carolina. And then you can see the local relative risk as well. So now that we have the clusters, great, but we don't really know why those are occurring. So we went ahead and did some modeling with different factors. But before I present that, this is a cool output that you get from SAT-SCAN, which gives you more information about the cluster. So you'll have the cluster number, and it's ranked by log likelihood. So how likely did it happen? The location, so each cluster will have a center, and then, of course, the zip codes that are around that. So we have the number of zip codes in a cluster. For example, cluster 1 for suicide has 20 zip codes. The number of observed suicides in a cluster, say 55, and then 23.46 for the expected. Hence, we get a relative risk of 2.4. So where we have more observed than expected cases, the expected's computed by the population distribution. And then, of course, we have the p-value. Are the clusters significant or not? We had 2 that were not significant for self-injury at the bottom there, 11 and 12. But then looking at our regression analysis, we found some really interesting yet discouraging things. You'll see for military members for our individual level predictors for suicide high-risk clusters, the risk ratio is 1.86, and that was significant. Some other factors were those that were American Indian and Alaska Native. We have micropolitan and rural and isolated being predicted factors of the suicide high-risk clusters. Interestingly, rural and isolated had a lower risk of suicide in the community level model. And then, as we would expect, income had a higher risk, low income had a higher risk of suicide. And then we get down to model 2, which was looking at our self-injury outcomes. And we had some similar results, but we had insurance data for this, where those that had Medicaid had a higher risk of self-injury, which is important because Medicaid was expanded in 2014. And I'm seeing that those with Medicaid have a risk for a lot of things in other studies. And those that didn't have insurance had higher risk of self-injury. And what I thought was one of the more interesting ones was mental health facilities. If you had one in your zip code, you had a lower risk of self-injury. So definitely access to mental health services is important. So all in all, suicides were 2.5 times more likely in low-income areas. The Native American suicides, some uncertainty there because we only had 25 samples, but it showed that there was 14 times more in those areas. Same with military personnel had a high risk. We know that there's a lot of military personnel in North Carolina, so definitely an issue. And then for self-harm, white, non-Hispanic white, Medicaid, self-pay insurance, micropolitan, divorced, and low-income areas were the highest risk. And so overall, for the first study, we found significant spatial trends in self-injury and suicide outcomes. So the risk for adolescent and youth suicide was 3 times higher in high-risk clusters than everything outside of that. Then I already named the factors, being Native American, previous military history, and living in a micropolitan zip code. And so really, we want to utilize this to tailor targeted interventions, whether we're delivering telehealth services, more education, and different strategies to address interventions for these vulnerable populations. So that was for adolescents, but within the same data set, we also had all age groups. And since the pandemic started to die down in terms of the transmission levels and all of the interventions and whatnot, we wanted to look at mental health before and during the pandemic. So this paper was published over the summer with Sophie Ryan, who's now a lecturer here as the lead author, Jen Runkle, Luke Vertis, who's I think an undergrad here, and Maggie. And we evaluated essentially co-occurring space-time clusters of depression and suicide. So is there simultaneous excess incidence of both depression and suicide in any place in North Carolina? So studies haven't really looked at this because it's obviously very new, and we had a great data set to do that. So we wanted to evaluate these patterns of emergency department admissions for depression and suicidal behavior. So our kind of baseline before the pandemic was March 2017 to February 2020. And during data from March 2020, when the first case was really reported, and December 2021 was the end date. And so just some descriptive statistics. We have average monthly visits. We have obviously sex, male, female, we have race, and then we have our age group. So we have under 9, unfortunately, and then 10 through 14 all the way up to over 85. So we have this for both depression and suicide related outcomes. So using a similar approach with the SAT-scan cluster detection technique, but instead of the spatial technique, now we have space-time. So we want to look at clusters that are within space, but also over a time period. So is there a cluster that appears in Charlotte for 3 months, 10 months? Is it significant, and so on? Then with the multivariate model or approach, you could see if there's simultaneous excess incidence or risk of both. So co-occurring depression and suicide in the same area. And the cool thing about that approach is that you can still detect univariate clusters if there's enough evidence of the individual outcome. So you still might have just the suicide cluster or depression. And so this time we adjusted directly in SAT scan again for race, age, and sex. And we wanted to see how stable the clusters were comparing the two time periods. So is there an agreement or disagreement of the clusters for the pre and during time periods? So we use something called a RAND index. It's bounded between 0 and 1. Closer to 1 means more similar. So the cluster appeared at the same place in time period 1 as in 2. And we could kind of determine if there were kind of new clusters appearing that were there before. And we also wanted to see if there was a shift towards more urban and rural areas comparing the two time periods. So that formatting didn't hold up, but that's okay. So essentially, this is just the cluster output where we have a bunch of multivariate clusters. You'll see in the maps in a second. So for example, cluster 1 here, we have a cluster that lasted from March 1st, 2017 to February 28th, 2018. So quite a long time, and it comprised of 24 zip codes. So like I said, it lasted 12 months. And then it was a co-occurring cluster. So you have both depression and suicide related outcomes. Here we had 17,500 observations of depression and 4,500 observations of suicide related outcomes. And that was for the pre-pandemic. And during the pandemic, the relative risk actually increased for depression. And we had about 7,000 more depression cases. So each cluster will have, whether or not it's co-occurring or not, or you have a univariate outcome, and how long does it last. So here, this map just shows the change in relative risk for the univariate depression clusters in the top. And then on the bottom, you have change in relative risk for univariate suicide-related outcomes. So anything in blue, we have kind of a decrease in the relative risk comparing the two. And then anything in our dark red where you have kind of an increased relative risk. So the outcomes are becoming worse over time, at least comparing these two cross sections. And so this is just some maps looking at of the outcomes. A and B is the pre-pandemic period. C and D is during the pandemic. So on the left, we're just showing where the clusters are. And on the right, we show the relative risk of every zip code within that cluster. So most of the clusters are co-occurring, but you do have some clusters in yellow, orange on the left there, especially in the north and south region of North Carolina, and a couples in the east that are either depression or suicide related. But as you can see, a lot of areas are co-occurring, and you see more clusters of depression, of just depression in the pandemic period. And as you saw in the previous map, you're able to see kind of the change over time. And then looking at our RAND index, looking at the similarity or dissimilarity across the two time periods, you'll see that for suicide related outcomes, the cluster locations were most similar pre-pandemic and during the pandemic, 0.79. So it's the max would be 1. So somewhat stable. The multivariate clusters of both depression and suicide had an index of 0.62. So there were some new clusters appearing, some new zip codes that weren't appearing before. And it kind of makes sense with the map if you look at univariate depression, 0.61. So some stability, but still areas that had clusters of depression that did not before. So overall, poor mental health outcomes are pervasive. And during the pandemic, it got worse, right? And many locations have co-occurring mental health clusters, suggesting high mental health burdens among select populations. So yeah, this is something that we need to address. I think this is one of the first studies to show kind of pre and during COVID-19 mental health outcomes. And overall, we saw more suicide-related outcome clusters emerging in the later months of the pandemics. So July 2020 to April 2021 as compared to the early months of the pandemic, so March 2020 to June 2020. And then we have a few more papers in the works, so hopefully stay tuned for that over the next couple of months. But now I'll shift towards some work I've been doing at Hopkins, looking at this recent publication in obstetrics and gynecology with a couple of gynecologic oncologists at Hopkins and my former postdoc advisor, current faculty mentor, Frank Carriero, who's the director of my spatial center. So the doctors there, the MDs, wanted to look at access to these specialists across the country. Because if you have access to a gynecologic oncologist, your survival is going to be significantly better than just seeing a traditional OBGYN or general surgeon. And every year, 100,000 women are diagnosed with gynecologic cancers, and we have over 30,000 deaths. And it's rising. So the incidence and death rates from the most common malignancy, which is endometrial cancer, is rising, and it will overtake colon cancer by 2030 as the third leading cause of cancer for US women. And like I said, there's a survival advantage when treated by these specialists, but there's not many, as you'll see. And small increases in travel distances result in negative effects on cancer outcomes. So even small distances, it might be 25 miles. And this is common across other diseases as well. It's quite intuitive, right? The farther you have to travel, the more negative the health outcome might be. And that's in the second paper. I'll talk about that later, dealing with the CDC data set to look at early and late stage cancers, but this is just potential access to this providers, not actually if you have early or late stage cancer just yet. So I use the spatial modeling approach and spatial access model to capture potential disparities of gynecologic oncologists in the US at the county level between 2001 and 2020. So we had a physician database of all physicians that were active. So when did they graduate? When did they start practicing? So we both had early and late stage or later career physicians. But essentially, without going over the model in detail, it's a floating catchment area model. So we look at the physician to population ratio, and it includes a distance decay. So the farther away you are from that location, you're going to be given a lower weight. So the closer you are, you're given higher weight to determine that potential access score. So looking at some descriptive stats of the situation in the US, the workforce more than doubled since 2001. And we looked at this in 4 5-year cross sections. Like I said, starting in 2001. So in 2001 to 2005, there were only 21 early career physicians, 571 late career physicians. So this is going to be an issue over the next decade, right? And as we see, we go from 21 all the way up to 607 early career physicians in 2016 to 2020. There were only 12 early career rural physicians, and that pretty much remained the same until the latter half of 2016, 2020. So essentially what the takeaway from this is most of them are practicing in urban areas with a lot of resources already, and you'll see the statistics, and it becomes quite discouraging. So this map here just shows the distribution of physicians at the county level in the US. Anything in green has at least one gynecologic oncologist. Anything in gray, nothing. And this is just the time series going from 495 in 2001 to a little over, or 1,178 in 2020. So more than doubled, but they're still practicing in the areas where they already have good resources. So you'll see some side-by-side maps of where access increases in a second, but it's pretty discouraging. There's only 245 counties that have at least one provider and 2,864 that do not have a single specialist. So this is the result of the access modeling. You get a potential access score for each county. And we have our 4 or 5 year cross sections, and we looked at the access scores in a quantile range. So Q1 would be our lowest access. That's actually no access at all. All the way up to quantile 5, which is the most access in terms of distribution of the access scores. So you'll see in A, in 2001 to 2005, there's no one practicing in Montana, and Wyoming was an issue as well. North Dakota didn't have a single provider. And then over time, you see some of the states out west started to become darker brown. So they started to have a provider. There is less population there, so the access score is going to be higher because there's a higher physician to population ratio. But you can see it's mainly just in the Northeast, right, where we have a lot of medical resources. A lot of urban areas have these specialists, so that becomes an issue when we think about access to care. So in total, 2,800 counties, 57.4 million women don't have access to an active provider. There is no increase in rural providers observed over time, other than a few counties out west. We did some modeling as well, looking at different demographics. So it's not just geographic disparities, it's also racial disparities, ethnic disparities. White women exhibited significantly better access than non-Hispanic, Black, Hispanic. And strikingly, the Native American, American Indian, Alaska Natives pretty much had little to no access for the entire 20-year period. We know they have a lot more health problems compared to other minority groups. And then the findings suggest that there's minimal improved access to care for many rural and underrepresented at-risk women. One thing I should add, that the model had a cutoff of 100 miles. So can you access a provider within 100 miles? We also did sensitivity for 50 miles, and the results were somewhat stable. So yeah, 57.4 million women don't have access to a provider within 100 miles. Not good. So we call this the paradox of more docs. That was in the title originally, but the editor didn't want it for whatever reason. I thought it was pretty neat. And a good summary of what we found. An understanding of the impact of gynecologic providers on cancer outcomes is essential, and I just secured a pilot grant to do this with the CDC data of outcomes per county for a 20-year period. So I'll begin working on that this fall. And yeah, I want to see, does it impact early versus late stage cancers across different racial and ethnic groups, looking at travel time rather than distance along the road network, and a bunch of other cool things. Since it's costing me $10,000 to even get the county level data, I might as well maximize what I'm doing. So obviously I don't have all day to talk about what I've been doing. I wouldn't have imagined I'd be working on all this cool stuff at Hopkins since I joined. Everyone needs spatial. We get calls every week. It seems like I just got on a new hepatitis C project last week. Another one I didn't add on here is we're looking at how effective are these neighborhood level gun violence interventions in Washington, D.C. with our Gun Violence Institute. Dan Webster is kind of the national figure in gun violence, and he's showing that better laws reduce homicides and suicide outcomes. So we're trying to see, are these people out in the community that we hire that volunteer their time to go and try to keep the peace, is it actually working? So we're doing some causal analysis over time. He did this in Baltimore, but now we're doing it in DC, working with the government there. Another big project I'm just wrapping up is looking at the catchment areas of our comprehensive cancer center. So over the past 2 years, I've had funding to kind of define what a catchment area is for a cancer center. There's not a objective way of doing that in the literature. Everyone just says, oh, this is what I think is important. But I think I determined a method to make this uniform to compare multiple catchment areas or multiple cancer centers by just looking at the closest patients. So look at the 75% closest patients to the cancer center, all the way up to 95%, looking at patients outside of that catchment area based on travel time, and then looking at various outcomes like different types of cancer treatments, early, late stage, and so on. We're finding that medics have higher risk of late stage cancer. They're not getting screened early enough, and it's a problem for minority groups. So even at a place like Hopkins, this is still a problem. We need to do a better job of allocating care. Some other quick things. We developed a smartphone survey app using something called ecological momentary assessment. So we have this pilot study going on where we're collecting data. People go on their phone, walk around all day. Okay, I'm going to smoke. This is where I'm smoking. And then we use a combination of kernel density and some other things to look at where are their highest risk areas of smoking. So after 2 weeks of data collection, then we draw the geofences. And then for 2 weeks later, people are going to go about their day in their activity spaces. They enter that geofence, you'll get an intervention like, okay, go draw if you like drawing, do something with your hands, don't smoke. Some preliminary evidence that it's effective. So the NIH is supporting us to do that. And the first paper on the method is out there. We're working on the pilot right now with our actual cohort. And then I did a lot of work on COVID. I have, I think, 10 papers now. Our big project was syndromic surveillance of COVID-19 using crowdsourced data. So we made a phone app to log your symptoms every day. And using cluster detection, we were able to predict actual clusters of COVID cases within 4 days in advance. So that's published, but it wasn't utilized enough because of the politics. Governor Hogan in Maryland had his own agenda. We said, here's a free tool. You need a lot of money for PR. So we had, over 100,000 people in the US, but you still need that PR to get people on board, and then the distrust in public health. And it wasn't a good time for PR for science. So that was still successful. And we learned that it could be used for other things like the flu. And then speaking of cholera, we have this data in Nigeria looking at how effective are these case area targeted interventions. So if a case of cholera pops up in a village, teams will go, and within 150 meters around the case location, they'll deliver aqua tabs, other various interventions to try to mitigate the transmission. And no one really knows if they were effective yet, but we're writing up the paper now to submit to the Lancet that we found that it substantially reduces the risk of cholera transmission. Looking at a variety of different things that they do. It's not completely causal. It's using cluster detection and some regression. But we found that, yes, these CATIs are great because they're spatial. It's based on the first case, and then let's get everyone else involved before they get the disease. And then I do a lot of work on access, as you've probably seen already. We have an NSF in Florida and Michigan looking at how residential mobility, how many times you move across your life course impacts exposure and outcomes for different things like sexually transmitted diseases, access to care for children with birth defects. And then I think 30% of my salary now is for aging. A lot of these neighborhood level exposures that they were using were terrible. When they brought me on board, they were using buffers with literally everything known to man. Okay, if I'm an 80-year-old person, I go outside and walk within this 200-meter buffer. Oh yeah, I'm going to go to a strip club. I'm going to go to a peanut shop. These are all locations that were considered in the exposure. I'm like, this doesn't make any sense. So now we're reconstructing these historical exposures over time with theory and better data that it's not based on these Euclidean buffers, which is a problem in a lot of areas, obviously. So we're writing a renewal job with that. And starting in October, we have this sub-grant in Milwaukee, Wisconsin, looking at kind of the spatial distribution and reasons behind overdoses and overdose deaths of various drugs. Some of the preliminary data shows that the quality is different among different subpopulations. Non-Hispanic, Black, and Hispanics have worse quality drugs. There's more likelihood of, say, fentanyl and other things that they're cut the drugs with. So minority groups are more likely to die, at least in Milwaukee. So we're trying to figure out what's going on with that, working with toxicology reports and other things, police reports. And the end goal is to try to also implement, or not implement, but where do we place vending machines of Narcan? They're starting to do this in Vegas. So that's one way of hopefully saving someone's life. You could go to CVS, I think, or at least in Maryland, you could go and get non-prescription Narcan, like I could go get it and just have it on me in case I see it. I've seen quite a few overdoses in Baltimore, unfortunately, just walking to work or whatever. So time is of the essence with that. So I think that's good that it's not prescription anymore. And where am I on time? Okay, doing pretty good. I guess lastly, since it's made up of undergrads and master students here, may not know too much about medical geography. How did I get here? I'm a geographer, right? I started with coral reef conservation and then spatial optimization of nature preserves, and I got into health in my PhD. So what are some careers? So academia, obviously, plenty of opportunities to be a professor. You could be research associate, scientist, be on faculty, or you could be on staff as a researcher as well. At Hopkins, this is quite common. We have a variety of people working on different things. If you're just interested in research, you could be an associate rather than a professor, obviously. The EPA, WHO, and NIH has a lot of spatial epidemiologists. There's a lot of different programs and grants that they fund, but also in the scene, they're also doing research on their own, so you could work with them. The EPA is quite good as well. The CDC has a wonderful spatial program for health. There was a job opening, actually. My buddy that graduated with me at Charlotte is in the CDC down there, and they have the ORISE Fellowship with Oak Ridge National Lab in Tennessee, a partnership to fund fellows, post-bac, postmasters, and even postdoc. So they have their GIS, Geospatial Epidemiology program, and that's really the best way to get into the CDC because you don't have the clearance yet, but it's really hard to get into the CDC proper without having some sort of fellowship. And then their spatial division at the CDC, which a lot of people maybe not know who they are, is the Geospatial Research, Analysis, and Services Program, or GRASP. I graduated the same year with Ari Whiteman and Claudio Owusu, who went down to work for GRASP. Ari's still there, and Claudia is doing some nonprofit stuff now remotely. So also a wonderful program. And the Division of Population Health, there are some geographers. I think Kevin Matthews was part of the Health and Medical Geography group of AAG, was at Population Health doing a lot of rural health on COVID before I moved to Case Western in Ohio. And then finally, you could look at public health agencies and hospital systems. We have some wonderful PhD students in our school and one in our lab that's a PhD student in Epi who came from a hospital system doing on tobacco use, access to tobacco retailers and lung cancer and stuff like that. And this is all GIS. Environmental health officers are good, research analysts, public health scientists. Any county with a public health agency should have some spatial person. And I guess actual last, consulting too. People pay a lot of money for maps. Put yourself out there, even if it's just on, forget the website where you could be doing freelance, just it's like a LinkedIn for freelancers. But if you're involved with health, there's a lot of things you could do, like nonprofits. Two of my former students formed this nonprofit to look at climate and health in Liberia, and they asked me to be the scientific advisor. So we're working on getting that funded. It's already approved, so we hope to do some chronic disease surveillance in Liberia, looking at hypertension, looking at mental health and various things before we kind of have a track record to get more substantial funding to look at things like Lassa fever, which is a vector-borne disease caused by these mice, which is a neglected tropical disease. And other things. I don't know how I have time to sleep. But yeah, I think it's time for Q&A. I'd like to thank Maggie and App State for hosting me. This is wonderful. I did my PhD and master's at Charlotte 2 hours from here, so it's nice to be back. I miss North Carolina. Working with Sophie, Lauren, Luke, Sarah, and Jen Runkle has been wonderful. I like to support geographers as much as I love being in public health. And I'd like to acknowledge my department for really loving spatial. Our chair, who's outgoing, has been there for a while. He's big in AIDS research, but he helped Frank develop the center, I think, maybe 8 years ago. So we have a house for spatial epidemiology. Tim Shields is our co-director, and my students and collaborators. And I always like to acknowledge my mentors from the past. Eric Delmel at UNC Charlotte was my master's and PhD advisor, and he's just like a wonderful person. I'm a really good friend with him, and we still work together. He was the one that got us the NSF as the PI, and now he's at Penn. Sadly, Charlotte's going to miss him, but yeah, and thank you for attending. It was a good turnout. I appreciate your attention. Feel free to email me. I always like helping students no matter what stage they're at. So if you want some papers or just general advice, I'm happy to hop on a call. No worries. Well, thank you.
Wonderful presentation. Also, I have a question about cluster analysis. So for the exposures and the disease, the relationship between them, so we can have like relative risks, odds ratios, or hazard ratios. I'm wondering, so for the maps, because the relative risk will be generated on the map, I would like to know, so you will use the relative risks generated by the traditional software and the methods like SAS, SPSS, or R, or directly from some spatial analysis software.
Yeah, the equation is very similar to the traditional relative risk, but this time it accounts for what's going on within that certain area compared to everything outside of it. So what is the risk compared to everything outside of that? So yeah, in the unadjusted sense, it's just looking at the population and the cases, but when we adjust for the covariance, well, to come up with the relative risk. So the software does that for you on the fly, and it just spits out the relative risk. So if you were to compute it on your own, probably could get the same answer.
That means so we can use the relative risks from the traditional software and then put on the map.
Yeah, and then you could do your cluster detection too with the cases and population just to see if it aligns. And you could bring in expected values from, say, a regression fitted values after you're adjusting for all the covariates and do that directly instead of adjusting for each variable separately in the software.
Yeah. So I don't know whether like the complexity analysis, like visions analysis or other like using specific software for spatial analysis.
What are the specific software you're asking?
Like
So that for that one, it's StatScan.
also you use
StatScan for cluster detection, yeah.
Okay.
And there's an R package too that's not well developed, but I kind of came up with my own tutorial because they forgot about it years ago. But if you want to automate things for daily surveillance, like I did in COVID, it needs to be automated in R. So we figured out how to do that. So it's a good way to, yeah, use some coding to make sure you don't have to press a button every time. And then there are other clustering software, FlexScan, there's Spatial Epi from Paula Raja in Spain. And yeah, R will probably have some packages too.
And for the first application, if I maybe and other colleagues. So you use traditional software or just
we use StatScan, which is a free standalone software, and then we use regression afterwards to see what's going on within the clusters.
okay. If I use like SAS to have some like hazard visuals, and then so you use like ArcGIS to have a map using the hazard visuals I generated.
Yeah, exactly.
It's also acceptable.
It'll also pop up in Google Earth. It'll spit out kind of the KML files, and you can look at that. But obviously, it's not presentation ready. Oh yes, thank you, Laura.
Thank you.
But I'll ask it now. So, is it code for suicide data? Is it code for pushing of the suicide or the location of the or
Maggie will know.
so the obvious point? It seems like that is a college community. because it can't. You know what I mean, like.
Yeah.
It gets before the, but yeah, that's it. Yeah, that was just.
Yeah, totally, yeah.
Yeah, like we will in Milwaukee with the overdoses, we'll see where they overdose, where they buy drugs, where they died, where they live, so we can see the entire activity space. But I don't know if there's literature out there showing that suicides happen within a certain distance from home to kind of say, okay, zip code's good enough.
Didn't John have the same problem?
Yeah.
John had the same problem with the things like water.
They were all drinking at the beer pub.
Talk about how you drive, you proceed to, and then the process of you actually accessing that data, and then how much you paid, and also the procedure of how you had to be in this kind of closed space.
I guess I'm gonna have nightmares at the Comfort Internet. Yeah, so that was like a year-long process. We had you could go onto the data statistics, National Center for Health Statistics website, go to their form to request more fine level data, which I don't agree that county level is fine to expose people's whereabouts. But anyways, yeah, so it's this long thing. You have to provide table shells. What exactly are you going to present? What maps are you going to show? What are the captions? What are some expected uncertainties? So everything that you actually produce during the research has to match that proposal that's approved. So once that's approved, then we had to go to a notary public and get a data use agreement notarized. And I had to do that twice because they screwed up the first time. Oh, this is the wrong form. This was last year's. So that was like another month of waiting. And then after that, we have to, yeah, it gets approved. And now I have to send the data that I'm using, the public use data, census data, send it to them with my R code to link it. And then I have to pay them $10,000 for the data, $300 a day to go to Hyattsville, Maryland. Thankfully, I'm 20 minutes away. No internet, no nothing. Make sure my code works beforehand, spit out the results, give them the figures. They review the maps. Okay, this aligns with what is said on the proposal. Otherwise, you have to spend another $100 on an amendment to include that extra variable or table, or whatever it is. And yeah, maybe in 10 years, I'll figure it out. So yes, I don't think that's the case with a lot of things. NIH is much better. I was on a panel with the aging subsection, how to provide better data that's accessible to everyone, not just people that have good money with grants. If I lived in California, all the data centers are in the East Coast. How am I going to work on county level cancer, which should be publicly available already? So.
So on the, in the email showing relative risk, is that, so when I did multivariate question, I got relative risk for each condition that was included. So how is that relative risk? Is that an aggregate?
Good question. Yeah, it's combined relative risk. You could do the average, you could do the sum. I mean, I forget what I suggested. I did this in my dengue, chikungunya, Zika co-occurring paper, where I have the combined relative risk, but also the separate relative risk, just to kind of show the magnitude. Okay. Yeah.
One more, but not related to the. So I'm just curious. You've done some really great research about pre-pandemic and during pandemic. Like I got some COVID during Zoom. I'm still talking because of that. So I can hear most people like you can have heart problems after. So is there anything to tell you about that and how long?
Yeah. So at Hopkins, we have a huge national level longitudinal study called Long COVID. You could actually sign up, and every 3 months you fill out a follow-up form as your symptoms improved. and other various things about day-to-day, your health, what prescriptions have you started? Did you see a new doctor? So it's going to be a while before we fully understand long COVID. But that's probably the first example of, linking space and time with getting COVID multiple times, because it'll ask, did you get COVID again? Were you vaccinated? Did you get a booster? We don't know about the variant because I don't think we collect that, but yeah.
Thank you, Michael.
Thank you.